Path fracture in the pediatric population, this can be associated with benign lesions such as a UBC or possibly fibrous dysplasia. In the adult population, it's a lot less likely to be something that's benign, oftentimes associated with metastasis or primary malignancy. So now, what is the lesion? What is the bone doing to the lesion? This is this Lodwick classification that I've always found helpful in trying to visualize this. I kind of talked about this a little bit before, and as I said, those two questions, what is the lesion doing to the bone? What is the bone doing to the lesion? They do kind of overlap a bit. So the different borders you can have are when the lesion is well circumscribed, that's what we describe as geographic, which in and of itself is more reassuring for a benign entity. The 1A is a sclerotic rim or a rim of reactive bone. The 1B having a well circumscribed border, but not having that rim of reactive bone. And then 1C is starting to get into the ill-defined territory. And then our non-geographic patterns are moth-eaten or permeative. So a geographic 1A lesion, as I said before, has a narrow zone of transition, a rim of reactive bone. 99% of these are benign. Examples include non-ossifying fibroma, osteoid osteoma, this entity called LSMFT, liposclerosing myxofibrous tumor. It's kind of a term that the radiologists use that I'm not sure has a lot of pathological correlation, but they look at something and determine that we don't need to biopsy it. And they say that if we were to biopsy, it would probably have those features in it. Fibrous dysplasia, LCH, ABC, UBC, or Brody's abscess, those are all lesions that can have this border. When we get to the 1B, so lesions that have a narrow zone of transition but no rim of reactive bone, these can be benign, but they also can be active or aggressive, such as giant cell tumor or ABC, osteoblastoma, metastasis, or myeloma can all appear like this. And then we saw this X-ray before, but 1C border, so it still looks geographic, but there's a wide zone of transition, no rim of reactive bone. This is definitely a more aggressive finding. Things like early osteosarcoma, early chondrosarcoma, giant cell tumor, Brown's tumor, LCH, osteomyelitis, metastasis, or myeloma. And then this is a nice X-ray because it shows both of the aggressive findings, moth-eaten being on the top part of the X-ray with these little holes that are put through the bone, and then permeative. You can imagine that whatever this lesion is just blew right through the cortex and right through the bone. This is a very aggressive finding. Something like this is often associated with lymphoma. So you don't need to memorize this classification, but I just think it serves as a useful tool to help you visualize what the different margins are and start to grasp the significance of it. And then our next question for what is the lesion, what is the bone doing to the lesion, is periosteal reaction. It's not just is there a periosteal reaction, but look at it and determine what type. The different types of periosteal reactions you could see would be solid or unilamellated, just having one layer. Those both are generally associated with benign lesions. It could be a healing fracture. Sometimes you do see this in infection and osteomyelitis. You start to see these other four, multilamellated, multilayered, onion skinning might be another name for that, spiculated, Codman's triangle, and buttress. These are all suggestive that the lesion is growing faster than the body is able to contain. Specifically, spiculated is often associated with Ewing sarcoma, and buttress is often seen in the posterior distal femur with something like a periosteal osteosarcoma. These are some examples of lesions in the different periosteal reactions. You can see the multilamellated periosteal reaction for the lesion on the left. This is a Ewing sarcoma in the middle with the hair on end spiculated pattern, and then this is a Codman's triangle from, I believe it's a metastasis on the right. Are there any clues that provide information about the type of tissue within the lesion? This is the last question, and it specifically refers to matrix. The three types of matrices are osteoid, chondroid, and fibrous. Osteoid matrix is described as fluffy and cloud-like, or ivory and dense. This is a good example of a Periosteal osteosarcoma. It's a classic location on the posterior distal femur, and it has a prominent amount of fluffy looking matrix. And that you should learn to differentiate this from chondroid matrix, which also has a very specific appearance. This is described as stippled or rings and arcs, as you can see right here, which is almost diagnostic of, this is chondrosarcoma in this case, with a lesion that starts inside the bone and is now growing and extending outside the bone. And then fibrous, this is described as ground glass. Can be a little more difficult to call compared to osteoid or chondroid matrix. Sometimes it's best seen on a CT scan, but this X-ray is a good example of a well-circumscribed lesion with a rim of reactive bone in the femoral neck, with just kind of a uniform hazy appearance to the lesion that is definitely suggestive of fibrous, and the diagnosis here is fibrous dysplasia. So, as I said before, we can put this all together where you have the age of the patient plus the location plus the radiographic features can lead you to a diagnosis. Perhaps we can, I don't think I can see a participant list right now, but perhaps I can have some of you guys jump in and interpret these x-rays for me and give me some of a differential. Would any of the twos like to start?
Yeah, I can give it a try. Okay, so we have, so are those two different patients or?
Yes.
Okay.
So why don't you start with the one on the left?
Okay. So that looks like a lateral of the tibia. There is trying to zoom in here, pretty well circumscribed lesion in the tibial diaphysis. Looks like there's some cortical thinning. Looks like extra periosteal, and it's located like on one side of the bone, eccentrically located. It's non-homogeneous, so it has some like sort of a moth-eaten appearance a little bit.
Okay, I think that's a pretty good description. What sort of differential diagnosis do you have?
Do I get any clinical symptoms?
Patients had pain for a few months. His mom thinks that she's noticed a mass that's there. They went to the pediatrician who ordered an x-ray. Otherwise, the kid is able to run and doesn't really hurt too bad. No B symptoms, no night pain.
Okay. So it looks, I guess, like in terms of differential, you think of malignant versus non-malignant. So starting with the non-malignant, could always be an infection. Less likely given that he doesn't have any B symptoms, and his symptoms have been going on for a longer period of time, but it could be an indolent infection. Could have like a, in terms of malignant, like a periosteal osteosarcoma.
Does anybody, perhaps one of the older residents, want to chime in with some thoughts on differential diagnosis of anterior tibial lesions?
Hey,
I heard this
Emerson.
having fibrous dysplasia too.
Osteofibrous dysplasia.
Yeah, I think I heard a couple people say it. So when we see anterior tibial lesions, we often think of the main two things are adamantinoma versus osteofibrous dysplasia. Yeah, that was good, Olivia, pointing out things like, infection. I think an infection definitely could appear like this. There are other lesions, periosteal osteosarcoma. Perhaps, it is kind of stuck on the bone. Good to think about. So I specifically put this slide together to kind of show the difference between OFD and adamantinoma. They can appear very similar, almost identical, with this anterior cortical, expansive, bubbly, almost lytic appearance. And if you're given this picture on the OIT or the boards, the age can definitely help you out, where in somebody who's 8 years old, a younger patient, that's much more likely to be OFD, and in an older patient, much more likely to be adamantinoma. That's presuming they don't give you the pathology slides, which do have unique appearances, but I'll leave those to you guys to study for another lecture.
Are those a part of the same process? Like, is adamantinoma an OFD that's progressed?
No, I think OFD seems to be more of a, I don't know, in the spectrum of fibrous dysplasia. It's kind of a bony remodeling problem. Adamantinoma is considered a malignancy, a low-grade malignancy. When you look at them histologically, adamantinoma, it almost looks like, they call it carcinoma of bone. It's a good trick to help remember it because it looks like nests of blue cells kind of growing inside of the bone. So they are separate processes, Eric. So, Lou, I think I see your picture pop in at one point. Do you want to discuss some of these x-rays? You want to start with the one on the left?
Yeah, for sure. Can you hear me okay?
Yep.
Sometimes it mixes up on my speaker. So on the far left, we're looking at a knee, right knee it looks like, or left knee. And you can see a lytic lesion that's involving both the epiphysis and metastasis of the proximal tibia. And then it's more centrally located versus the other two in the middle. And you said this is a 12-year-old, so you're kind of using your age to also determine your differential for this. In terms of that's its location, it seems geographic, pretty well circumscribed. In terms of what the bone's doing to it, it doesn't have a very dense sclerotic border, but it does have a well-defined border.
Good. Do you see any matrix?
And then I was going to say, I think it looks, I was going to go with more of a cartilaginous matrix, but that's usually my weak point is describing that.
I think I'd say that's correct. It definitely looks like there's something inside of it, and it appears almost stippled or rings and arcs like.
Yeah.
Do you have a differential diagnosis?
Well, just based on its characteristics that I went through radiographically in the matrix, it seems more benign. So I'm thinking of more benign chondroid lesion.
What do you think about the differential diagnosis
like
of epiphysis? Okay.
And then, yeah, it is epiphyseal and also metastaseal. I feel like just based on where it is, I was going to have enchondroma as one of mine, and then I'm kind of drawing a blank on some others currently.
Can anybody else help out with our differential diagnosis of epiphyseal lesions? There's 3 main lesions that we think of.
What about chondroblastoma,
giant cell tumor,
Good. And the third?
clear cell maybe?
Exactly. So Lou, while you're correct, this could be something like a enchondroma. There's also, we like to keep those other 3 lesions in mind: chondroblastoma, giant cell tumor, and clear cell chondrosarcoma, which the giant cell tumor happens in, maybe not 12 years old, but can happen in people that are
older patients, right?
Yeah, 20s, 30s, 40s, and then clear cell chondrosarcoma is also an entity of adults. So again, in this case, the age plus the location plus the features really help narrow it down. And this one happens to be a chondroblastoma. So Landon, I think I saw you were on. Do you want to try the second one?
Yeah, sure. We have a AP of the knee, got a 28-year-old, so it's slightly mature. Got a lesion in the proximal tibia. It seems to have a well-defined sclerotic border, narrow zone of transition. does not appear to be extending into the joint. I would say that this is a benign appearing lesion. If we are still discussing epiphyseal lesions, kind of what we just said, I would say this is more likely the endochondroma. But we still have to keep in mind the other three: the chondroblastoma, the clear cell, and the giant cell tumor.
Yeah, this one's a good location and age presentation for giant cell tumor. So that's what this one is. The endochondroma does not tend to be an epiphyseal lesion. That it happens more in the metaphysis.
Okay.
And then, who would like to jump in on this third one? Is Joseph on?
Joseph is on. So we have an AP of a knee here, and a 68-year-old, so an older individual. You can see there's some degenerative changes in the knee. Again, we have similar appearance to prior radiographs there on the left. However, this one appears to be less well demarcated. It doesn't have a nice kind of circular appearance. It's somewhat homogeneous. It's both in the epiphysis and the metaphysis. In someone this old, I definitely want to inquire about prior cancer history. I think metastasis definitely needs to be on your differential for this patient.
Good. Yeah, this lesion has a more aggressive appearance than the latter two, which is why I included this specifically. You can see that while the lesion appears relatively well circumscribed, it does become more ill-defined, as you pointed out, which is definitely a concerning finding for an aggressive lesion. This one is, in fact, a metastasis. And then, is Alex on?
Yep, I'm on.
Would you like to tackle this one on the left here?
Yeah, sure. So you have a lateral of a distal femur, or a lateral of a knee in a 14-year-old. Looks like there, based on the arrow sign, there's a lesion in the posterior, kind of cortically based lesion in the posterior aspect of the femur. Looks like there's a little bit of a periosteal reaction, and kind of forming a buttress there. In terms, it doesn't really look like it's destructive. I don't see a huge soft tissue component. I don't know if...
Do you have a thought of whether this is benign or aggressive?
It looks pretty... It does not look very aggressive to me, but when I'm thinking about cortically based lesions like that with forming a buttress, I start to think of things like osteosarcoma. It's aggressive, so I'm kind of blanking right now on a more benign lesion there.
Does anybody else have perhaps someone a little more senior have a thought?
What about an osteochondroma?
Not a bad thought.
FFD.
What about a non-ossifying fibroma?
Those are all good. I haven't heard what it is yet.
Focal fibrocartilaginous.
Cortical desmoid.
This is actually an X-ray of a cortical
Periosteal osteosarcoma.
What was it?
cortical desmoid,
Oh, nice.
also known as a tug lesion. It's based on it's a lesion that forms at generally the insertion of the medial gastroc, and oftentimes on tests you'll be given axial imaging, such as an MRI, that will show a focal lesion back there. But you're correct, Alex, that this does have benign features. And while I see what you're saying, I talked about the buttress periosteal reaction. I don't know if I would truly call it that, because this lesion doesn't even really have a soft tissue mass of its own compared to the X-ray on the right, which this is, I can just tell you, a classic X-ray for periosteal osteosarcoma. Fluffy, cloud-like, large mass extending into the bone, posterior distal femur. All right. Eric, do you want to tell me about the X-ray on the left?
So we're looking at a 9-year-old female's, or I guess not, don't know if it's female, but 9-year-old AP of a shoulder. And looking at the glenoid initially, we've got kind of poorly circumscribed changes throughout the glenoid. I can't tell if that's honestly the quality of the X-ray or a lesion itself there. But I would say decreased bone density throughout the glenoid, with potentially a small soft tissue component adjacent to it, kind of superiorly, just superior to the humeral head.
What about the scapular spine or the acromion? Kind of not there, right?
Yeah.
What do you think?
Yeah, decreased bone density throughout there too, I guess.
Well, I know decreased bone density is the word. I would say this is more concerning for bony destruction.
Okay, yeah.
It almost looks kind of moth-eaten or permeative if you try to focus your eyes on it. So, well, I admit it's not the best X-ray. Do you think this is benign appearing or aggressive appearing?
Very aggressive.
Good. Do you happen to have a differential diagnosis for aggressive appearing lesions in the
flat bone
axial skull?
Ewing's.
Good.
Maybe eosinophilic granuloma.
Good.
That's what I've got.
Good. So, and then in a 9-year-old, what do you think, based on the age, the radiographic features, and the location, what do you think this would be?
Ewing's.
Good. And then the corollary to this is in an adult, we often see that flat bone lesions are more often to be chondrosarcoma, as evidenced here with this large expansile cartilaginous appearing lesion based on the left iliac wing. Who would like to tackle this one? Anybody interested in spine?
I'm happy to give it a shot. I like spine.
Okay.
Judging by the pedicles or the spinous processes, is probably the lumbar spine, but please correct me. Maybe a transition between the thoracic and lumbar spine. In any case, we have a sagittal or lateral X-ray of a spine with what pops out is a lesion of the posterior spinal elements, sort of in that second to last vertebra from the bottom.
Mm-hmm.
I don't see any extension into the anterior columns, but I think a standard differential that we use for posterior spinal elements or posterior column of the spine would be aneurysmal bone cyst. Would be one. Could also be an osteoid osteoma or osteoblastoma. Are kind of the ones that jump to mind for this area.
Good. This one is in fact an osteoblastoma. Hopefully they would give you some advanced imaging if they were to put this on a test question to help you differentiate between ABC and osteoblastoma. But when you see a large lesion, this one is not the best X-ray to show you osteoid or bone-like matrix formation of a lesion in the posterior spinal elements. Osteoblastoma should jump to mind. Who would like to tackle this one?
Hey, it's Brad. So it's an AP of the thoracic lumbar junction. See the bottom rib, so maybe that's T12 L1. L1's missing the left pedicle. It's kind of blurred out there, so it's the winking owl sign.
Good.
64-year-old, so obviously you would think malignancy first. So I bet that this is met, but can't ever rule out anything else.
You are correct. And I just include this slide to remind everybody that of this radiographic feature, but also you're probably not seeing this patient for this purpose. It may just be back pain in a routine spine clinic or in a general practice clinic, that it is important that you do scrutinize the x-rays to look for findings such as this, because even if the radiologist misses it, you theoretically can be liable for this. Matt, do you want to try this one, Braswell?
Sure, I can. So we have two different lateral x-rays. On the right side, it looks like there's, on the 64-year-old, it's the lumbar spine lateral, and there's multiple compression fractures. It looks like, difficult to tell the acuity of the compression fractures. Looks like there may be some mixed lytic and sclerotic changes in the vertebral bodies themselves, which would be concerning for, again, based on age, metastasis or myeloma would be ones that I was thinking about.
Good. Yeah, that one is in fact myeloma. What about this one here on the left?
So on the left, in the 34-year-old, looks like in the middle vertebral body there, difficult to say the level, but it looks like there's some possibly some end plate changes, and then some lysis of the bone, kind of in the central vertebral body there, and some kind of stippling around it, which is different from the bodies above and below.
Do you have a differential diagnosis?
So 34-year-old, certainly primary and secondary tumor would be, on the differential but lower. I would definitely be on the lookout for infection in this age group. Osteomyelitis would definitely be a thought of mine, or some vascular malformation.
So, and just to keep things moving, I'll tell you that this is a relatively classic appearance. So it's a somewhat poorly circumscribed lesion. You do see the bony trabeculae stand out a lot, these striations. This is a classic appearance for an incidental hemangioma. But infection and EG are also worthy to keep in mind on the differential. Do we tend to go till 7:30 or 7:15?
7:30.
7:30. Okay. Yeah, one more of these, and then we'll get to staging. Our staging talk real quick, and then we'll get you out of here. So, Elaine, are you on?
Yeah, I am. But I have no idea what I'm looking at here.
I'll save best for last.
Okay, well, this is a skeletally mature person, and it's an AP view of the cervical spine. I honestly have no idea what the lesion is that we're looking for.
Does anybody else see any differences or asymmetry, perhaps? Nobody?
Are we looking at asymmetries like within the lung fields, maybe? Or
This is a patient. This is an X-ray that was sent to me by my co-resident who practices spine in Alabama, and he picked up on this. The patient had pain in the right side of her neck.
There's something going on, I think, in the first rib on the right.
Ding, ding, ding.
From what I can see, I'm trying to kind of zoom in on it, but the anterior aspect of the first rib looks like there's kind of an expansile lesion. It's a little bit difficult for me to tell just from here with the overlying lung fields and the subsequent ribs and the clavicle, but I think that's the asymmetry.
And it's actually the second rib.
Okay.
The right second rib posteriorly has disappeared. This is what the MRI looked like. This was a Pancoast tumor that my friend identified in spine clinic. So it's just a reminder to always scrutinize your x-rays. Don't just look at the thing that you're, focusing your eyes on, but look at the whole picture. Okay? So briefly staging, there's the Enneking staging of benign lesions. This is typically described as there's 3 levels. We use, or latent is lesions of low biological activity, well marginated, and they're probably not likely to do anything. This is something like a non-ossifying fibroma. Lesions can also be active, such that they're potential to grow over time. They sometimes can be symptomatic. There's some bony destruction. So these lesions that are active, latent, we may not need to do anything about unless it's a really large lesion with an impending pathologic fracture. Active lesions such as an ABC, probably is best that we biopsy that, figure out what it is, and then potentially scrape it out and stabilize the bone somehow. And then aggressive lesions, these can cause bony destruction, soft tissue extension, do not respect normal barriers. This is something like a giant cell tumor. And then our malignant staging, you've probably seen this before. I can let you review this. The Enneking staging divided lesions up into intracompartmental, extracompartmental, low grade, high grade, if there's any metastasis. And from that, you can get your 1A, 1B, 2A, 2B, and 3. Most of our primary bone tumors present as 2B. And then AJCC staging for soft tissue sarcoma and bone sarcoma. I can let you guys review these tables on your own. But this is the staging that we typically use and discuss in our bone and soft tissue tumor group conference. So any questions?
Yeah, for testing purposes, do you think that it is worth memorizing the entire AJCC system?
No.
So that if they, okay.
They're not going to ask you that. Besides, it keeps changing anyway. So that you shouldn't be tested on that.
Exactly what I wanted to hear.
But I would use this. You guys can go back to this presentation. Those X-rays that I showed you with that, with the locations. Those are classic things to include in the differential for those specific locations. With the exception of I did not put an X-ray of a clear cell chondrosarcoma on the epiphyseal slide, but the rest of it should help you guys with some high yield memorization. So, thank you, everybody.
Thank you.
Thanks so much, Dr. Anderson.
Thanks, Dr.
Thank you.
Thanks.